Now let's try to look into lifespan issues. All right. Stop me if I am not able to connect with you, or I will not be able to show to you the PowerPoint or the slide. Okay, so let's see. Now, in anxiety, let's try to look into children. Children often do not have a lot of anxiety, especially they have not established yet ingrown relationship, no? Deep span relationship. But most of the time, children would actually have encountered some so-called separation anxiety because the attachment to a special member of the family is actually there, particularly when they go to school, no? But often it's not pathologic in nature. So when a child is only when a child is separated from those to whom he or she is attached, excessive anxiety will be there, especially during the start of the school year when they go to school. No. Oh, what happens is that when a child will have this anxiety, the child may refuse to go to sleep or to go to school at that. No. No, in going to sleep, remember this. So the chances are is that the chances will be like this. No, most of the time when they go to sleep, when they are children who are there, parents are there, but there will be a point that we need to be separated from them because we provide them a room. They're getting old already. So in that case, on the first night, they may refuse to sleep. And similar way, when they go to school, often they're always with us, but there will be a point that we are going to be separated from them when they go to school. So most of the time they will cry, most of the time they will not go to school. So in that case, that could be manageable instead. That could be that considered as pathologic in nature, no? You can always detect this. You can always see this. No, the most common sign of anxiety in children will be increased motor activity. You could always look at this. They would be rigidity. They would be like having what we call as hyperactivity. No, but seldom it becomes pathologic in nature. That's the thing. All right. Moving forward, older adults. Now let's go. Let's proceed on the older adults. Dr. Rose, I get a class. Yeah. Anything? Yeah. Okay, I'll call you after that. So let's proceed with older adults now. These are there are some life issues in this case. Most of the time, they would actually have anxiety, as the year imply. Most of the time, when they will become older adults, if you're going to look at different stages of development, they would be very active when they're younger adults, but often when they would actually get into older adulthood, sometimes they think that they're very useless. You see? So anxiety in elderly people in this case has not been investigated, although there are so many concerns that could be brought about by their separation from their job because they are already retired, from the separation of, from their separation from the things that they love. You see? Now, there is a consensus among clinical gerontologists wherein anxiety is a very common response to the stresses of late life. Now, when you're going to be retired, there would be so many stresses. This is the reason why we keep on telling that when you are going to be retired, you can easily get old. For a simple reason that you will not do anymore the things that you love to do. Anyway, if you do things on the things that you love to do, you would be energized. So anxiety will not be considered, but only when you are going to be separated from it, that will be the time that you may encounter severe anxiety. No, you may develop already in this case forgetfulness. You may develop new illnesses, and there are other people who would actually develop, other than anxiety, depression. Okay, among others. And then other old people will also result into what we call as alcoholism. No, they may not take drugs, but they take alcohol one sip at a time. So that is usually some of the concerns that we have. But generally, among older adults, they are very resilient to anxiety as long as they would stay relevant. That's the thing. The only thing is that adult people, elderlies, do not perceive that way most of the time. And to make the matter worse, that we don't recognize them. That's why they would often result into depression and anxiety. Hand in hand, the two will actually go together. That is usually the problem that we have. So no wonder if we are going to see patients who are very old, we can always say that they are anxious or they could actually be depressed. All right. Now, how do we assess? Very standard, generic. No, we are always going to observe their behavior and appearance. We have to record that. So the way they carry themselves, the way they fix themselves, the way they fix their hair, among others. No, we're going to look into that one. We're going to record their emotions and the mode. Emotion will be immediate emotional responses, and the mode will be a long term. No, we're going to look into behavior, the thoughts, beliefs, and perceptions. We can always assist that by asking them some theoretical questions, and we can always observe their trends of thought, right? Then relationship and interactions, the way they're going to interact with us. Of course, obviously, as psychosocial nurses, we would always interact with the patient. We are going to look at them eye to eye. Sometimes, if they are anxious or depressed, it could always be noticeable because they refuse to look at us straight, eye to eye. They refuse to do that. They will do something else. Then we are going to look into their physical responses, especially touches. No, we touch, we hold their hand, or we touch them. We touch them on their shoulder, we pat them at the back. Because at this time, people must always be assessed in any way on how do we react with our therapeutic touches. And of course, we're going to look into the pertinent history of the present illness, the history when they are actually admitted, among others. No? Family history also is very relevant and very important to look into. Now, after assessment, we have to design our management. Of course, when we manage patients with anxiety, we are going to initiate pharmacological management or treatment. No? More often, we give them anxiolytic medications, or we call it anti-anxiety drugs. Anti-anxiety drugs are called anxiolytics, right? The medications that are typically used to treat the patients with anxiety are the following: benzodiazepines and antidepressants. No, benzodiazepines and antidepressants. What are some of the benzodiazepines that we may use? These are all prescriptive medications. These are all regulated medications. No, you cannot access this without prescription, like diazepam, like lorazepam, clonazepam, and alprazolam. No, these are the medications that are commonly prescribed to treat anxiety, including short-term, very situational anxiety and long-term anxiety. So we give these medications. No, of course, who will give these medications? The psychiatrist. No, or we may actually ask the psychiatrist or the attending doctors to order all these medications available or administered as necessary. So that's one of our treatment that we have when the anxiety is already on severe or on panic attack. Moving forward, most of the time as psychosocial nurses, these are the management that we can actually do. There is no need to prescribe because we can do it ourselves, no? So we try to enhance their defense mechanism and their coping mechanism. We try to do some activities. We try to do some relaxation training. We try to do some feedback or biofeedback. We try to do systematic desensitization, reframing, thought stopping, aversion therapy, social skills training, sports, art therapy, and others. No, sometimes we have to do this. As nurses, we should be trained on how to do this. No, the more we interact with the patient, the more they will forget about their anxiety. The more they can forget. They can forget. No, they can always divert from the anxiety that they suffer. Right? These are some of the nursing management that we can do, addressing diagnosis, like for instance, anxiety manifested by tension, distress, uncertainty related to threat to health, self-concept, and lifestyle. No, of course, when we are going to apply, when we're going to do nursing interventions in management, there must always be patient outcome. Always remember this. I believe you are familiar with this. No, when we're going to do the nursing process, there should always be the nursing diagnosis, which are based on signs and symptoms. That is, the things that we observe and the things that the patient actually observe by themselves that we do not see. So those are the basis of our nursing diagnosis. Now, in the formulation of the nursing diagnosis, we always need to utilize the guidelines given by NANDA, North American Diagnostic Nurses Association. All right. Now, when we're going to manage, there must always be a patient outcome. Okay. So let's address anxiety in this case. So the patient outcome is that the patient, at the end of your interaction with the patient will be able to demonstrate decreased level of anxiety. That's our ultimate goal. No, we will not eliminate anxiety. Anxiety will always be there, but at least we will lessen or we will decrease the level of anxiety from severe maybe to moderate or moderate to mild anxiety. We can never eliminate anxiety. Always take note of that. No. So the patient will report a feeling of less anxious after using coping strategies like doing sports or doing exercise or doing other manual work in the ward or doing other things like reading also. These are very helpful. No, we'll use coping strategies effectively when anxiety is recognized. So from time to time, you have to address this. No, so at the end of the day, the basic thing that you can actually do in order to address anxiety is that at least the patient will be able to utilize the available coping mechanisms that they could actually have. Coping mechanisms and defense mechanism. Now, you know the difference between the two. Defense mechanisms are unconscious process wherein a person will utilize their inner strength, their experiences in order to overcome anxiety that they may actually have. While coping mechanisms are what we call as the conscious process, wherein you directly do whatever needs to be done in order to eliminate anxiety. Now, moving forward, in order to do all the patient outcomes that we have, these are the nursing interventions, no? Speak in calm, quiet voice. Sometimes patients would be agitated. They do not want to hear our voice. Place patient in quiet environment, no? Not agitated environment. Sometimes in the hospital, it's either the ward is actually very crowded and noisy or the ward is too sleepy. No? Use discretions in conversations with patients and near patient's room. So we also need to recognize factors that may stimulate more anxiety. So instead of talking about anxiety-provoking experiences, we will refrain from doing so. No? Then reduce demands placed on patient until anxiety is reduced. Provide diversional activity and exercise. And then allow supportive others like clergy, among others, or imam, or the shaman. If they don't believe in religion, then there must be something that they believe in. We have to allow that. Now, always take note of the sequence because these are the things that we will actually look into when we address a specific problems, especially on patients with different psychiatric problems or disorders that we encounter in the world. All right. We also provide realistic feedback about patients' situation. We try to be very honest with them. No, we have to tell them what's wrong. We have to tell them that what they are doing is not actually correct at that situation, so that the patient will be able to be informed on what are they going to do. No, and the most important thing is that we will not give false reassurance that they will get well. How do we know that? You see? So we will actually look into that all the time. We need to prevent false reassurance. Help patient understand the anxiety by having him or her name the feeling. So something like they would trivialize the situation that they have, giving names, then after that, forgetting about that particular situations that they have. No, encourage patient to express feelings, particularly when you are conducting therapeutic relationship, when you are going to conduct your therapeutic communications and other psychotherapeutic activities. No, then determine patient's usual coping mechanisms. This is very important. You know this already beforehand upon doing your assessment. No, encourage patient to recall and think similar instances that they were able to get up alive from. No, especially if this is related to anxiety, then attempt to discuss what patient understands as cause of anxiety or panic. No, you try to look into that. Do not escape. Let the patient talk about it. Let the nurse talk about it with the patient so that the patient will be able to understand. Stay with the patient, but do not require explanation. Just sit down quietly, staying with them quietly. That's all. No? Provide measures to relieve anxiety, like in the case of giving warm bath, back rub, exercise, or massage. No? Or playing music, playing television shows at that. No? Discuss other techniques for reducing anxiety, like in the case of relaxation exercises, among others. No? Encourage slow, deep breathing exercise. It may help. Then assess him in learning the problem solving when anxiety is diminished through diminished, even though we need to let them or allow them to concentrate more as such. No, evaluate the need for anti-anxiety medications, but most often as nurses we shall be we shall be let's say mindful on the medications that they are going to use as much as we can. We must not give medication because I believe as a psychologist myself and a nurse, talking to the patient, having psychotherapy is more than enough. No? Then assess for potential injury. That's the first thing that you are going to do because the patient has a tendency to injure themselves and injure the others. No, that means to say they could actually be suicidal or they could be homicidal in nature. All right, these are some of the nursing management that we will do. Now, what about how are we going to manage patients with panic level of anxiety? The highest one, we will actually do pharmacologic management. We will do psychotherapeutic management. Other than that, we'll be using the following. No, we need to add this: take patient to a quiet area with minimal stimuli as much as you can. Let them relax. No, let them digest what they have because after all, the panic attack may just only be short-lived. Let them cry, let them shout, as long as they will be alone. And as long as the environment is not agitated environment, they will be quiet, no? Then as much as you can, prescribe anxiolytic medications as needed, no? And you need to stay with your patients through that, right? Now, one thing that you can actually do is to give patients a clear, honest feedback about the panic attack that they encounter. They should know that they should know that they are panicking attack. If you have seen a person in panic, look at the physiological reaction, look at the psychological reaction, look at the emotional reactions. These are all magnified and intensified. So moving away all the stimuli that can always remind the patient on this instance will be needed and necessary. Okay. So another problem that we have will be ineffective coping, individual evidenced by anxiety, fear, avoidance, and so on. So the problem is actually very clear: ineffective coping. No. So here are the patient outcomes. I would like you to read something about that. So in similar way, it's the same, no? The most important thing to summarize all these things is that the most important thing that the nurse will actually do is to make it sure that we will connect with the patient. You see, we will be able to do therapeutic relationship. We will be able to do therapeutic alliance. We will be able to utilize ourselves. We'll be able to utilize our relationship with the patient. That is the thing. Then the usual interventions that we will actually do is to conduct psychotherapy, to conduct play therapy, to to let them realize about the importance of using coping mechanisms among others. These are some of the things that we will actually do. So the same way, in the nursing interventions, we'll be utilizing a lot of lots and lots of our therapeutic relationship and therapeutic communication, no? Like in the case of verifying the interpretation on what the patient experiences, we will always say, you understand that you are afraid to go to the radiology department, you see? So in psychiatry, you are going to learn something about this, but as I'm telling you, do not prejudge the patient. You always has the tendency to verify if the patient feeling is actually there. So they tend to tell you if they are normal and they can actually they have the tendency to recover. They will always tell you honestly. No, so the same things over and over again that we can actually do, right? So some of the alternative nursing diagnosis that we will have would be comfort impaired, fear, gas exchange impaired, post-trauma syndrome, or sleep deprivation, spiritual distress. This is your topic for next meeting for your IRAT or TBL. Then thought processes disturbed, this is always present among patients with panic attack or with schizophrenia. And then violence also, as I mentioned to you, there is a tendency that patient may actually have violence, especially when the level of anxiety is severe and moderate, and at the same time panic. No? So now, when do you need to call for help as a nurse? You have already given your all to the patient, but still the patients actually are not responding. What do you do? So you need to call for help if there is an increased anxiety leading to refusal of treatment or non-compliance. So this is very important, non-compliance and refusal to receive treatment. No? So if the patient will not actually receive any of those, then there is a tendency that the condition may get worse. Then there is already the onset of paranoid psychotic thinking. So in that case, they're dropping down into psychotic disorder. Then onset of panic attack. Just in case you have moderate to severe anxiety, then there is the onset of the panic attack. The panic attack is starting. No? Then staff conflict over management of patient behavior, and at the same time there is an increased of anxiety over caring for a patient. No? Especially you do not want to go anymore to the patient because they are too much to bear. That will be the time that you need to call for help. Now, who to call for help? We will call psychiatric team. You know, the team, the whole team. A psychiatrist, psychiatric nurse, social worker, the chaplain, the colleagues who know the patient. Because of endorsement, we have to endorse the patient. So we have to call for the patients, for the nurses or other colleagues who know the patient. No? Then at the same time, you may call the family members and we may call the co-workers, especially in the case of restraining the patient if there is a need to restrain. All right? So that ends the chapter about anger. Is there any question that you would like to ask about anger? About anxiety, I mean, before I will proceed to anger. You see? No question? So
No,
we shall proceed to anger now. Did I record this anyway? Yeah, I recorded this. So I will start with problems with anger 2.2.1. Okay? So here. Yeah, so let's try to proceed in order to understand the problems with anger, right? The same scenario, right? So these are the commonly encountered problems. That's problem with anger among our patient. And later on, we have to look on the other side among nurses, no? You see, sometimes they are shouting at us, no? It's very scary sometimes, no? So let us try to move forward and understand what angry patient means. No? So these are the useful terminologies that we'll be using all throughout. Anger. This is the state of emotional excitement and tension induced by intense displeasure, frustration, and or anxiety in response to a perceived threat. Remember, the patient is actually trying to overcome the threat. So they need to be angry. The reaction, anger becomes a reaction in this case. This is a reaction. This is pertaining to your emotional excitement. Then there is what we call as assertiveness, no? Wherein the behavior is directed toward claiming one's rights without denying the rights of others. Assertiveness is actually right and good for all of us. Then we have the assertive training, learning behavioral techniques that allow an individual to stand up for his or her own rights. Then frustration leads to anger once in a while, no? Wherein patients could actually feel that they are unable to meet their goal. You know, if you're going, let's say for instance, the patient is actually thinking that tomorrow they will be discharged, but at the end of the day, when the following day comes, there is no discharge. Sometimes they're frustrated because they are already anticipating the scenario in their brain, in their mind, that they will see their family members, but they could not. So it's frustration. Sometimes frustration leads to anger. That's the thing. That's the thing, because frustration, you need to react. And when you are reacting, it leads to anger. That's the thing. Hostility is another one that we always see from an angry patient. These are the feelings of anger and resentment that are distracted. So we hate other people in that case. We are hostile to other people. We are threatening them. There is a feeling of suicidal and homicidal in this case. And there is also passive aggressive behavior, no? The tendency of an individual to get back to the person passively. I'll give you a very basic example in this case, like in the case of, you say, if you're going, try to be very careful when you go to the restaurant. You should be very good to the waiter. Let's say, when you are not very good to the waiter in the restaurant, or the one who takes order, no? Of course, the waiter will actually be feeling angry, but they cannot kick you out from the restaurant, or else they will lose their job. They may not be showing their hostility with you, because if they're going to do that, they may lose their job. So what are they going to do to express their hunger? You know, they prepare food. Then in the preparation of food, sometimes they spit on it, they add other things, and so on and so forth. No, or maybe they add spicy, they add a little bit chili, and so on. So these are some of the things. So when they offer it, you have no idea about what they did with the food. Oh, you see, that's actually passive aggressive. In that case, it's still acceptable, but the thing they did with the food that they offered you or they serve you is unacceptable, because they could have spit on it, or they could have prepared that not so careful, no, carelessly. And then, of course, there is what we call as rational anger. That is anger expressed in a direct, social, acceptable manner. In that case, you shout on that particular patient, or you shout in front of that patient, and so on. Often, this would always be acceptable, no? Without becoming hostile. Now, always remember this. No? Anger is a normal human emotion. It is often the most common human emotions that we have. I'm going to tell you that you are lying when you are going to claim that you are not feeling angry sometimes. Most of the time, anger is always a negative emotion, because it may destroy us, but anger is a necessary emotion also. That's why we call it very common, because we are reactive as a human being. We are reactive to any situation that we are in. We are assigned to another job. We are angry, isn't it? When we cannot get what we want from our husbands, we are angry. When our children do not want to follow us, we're angry. When our patients do not want to obey us, we're angry. These are all negative reactions that we have. We react. Isn't it? Did you feel angry this morning or within the day? Class, have you any feeling of angry within the day? Being angry within the day?
Yesterday, I fight with one patient.
Yeah. Normally within your family, sometimes now there are things that they cannot do. You're very frustrated. You react. You are angry. Sometimes you say, you know what I mean. The emotional reactions that you could actually have. Sometimes you express, sometimes you don't, isn't it?
Yes.
When you express, you could have shouted on your husband, you could have shouted on your children. Other people, when they could not express it, it's very difficult to hold it, no? Isn't it? Sometimes you are trying to get angry with your husband, but you could not express that. You just actually stay on one side. And isn't it? You do that sometimes? I do that also sometimes. I let it go. I let it pass. Especially when they do not do things that we want them to do. Oh, like for instance, you call them to eat already at dinner. They do not want to come because they are still playing, right? The dinner is served, but they do not want to come because they are still doing other things. We react, right? And these are all very common reactions that we may actually have every day. Patients also, so we react as a human being. So these are all common emotions that we could actually feel, no? It can result, from frustration, fear, or rejections. As I mentioned to you, frustration because you see, you keep on calling your children, your husband, but they do not come. Or maybe you are asking your promotion, but no promotion, among others. When handled appropriately, anger can help people, can help you to resolve conflicts and make better decisions. That's why it depends on how you are going to handle it. Anger is a necessary emotion. It will teach us how to hold. It will teach us how to be patient. It tells us how to preserve relationship. That's the thing. It can energize us into do immediate actions. It can also contribute to physical and emotional distress if handled in negative manner, that is destructive manner. That is why sometimes if you express, you shout on your husband because you're very frustrated, then the problem is if the husband gets back to you, there will be quarrel, right? Sometimes, we say I'm already old. When my wife will tell me something, I let it go. But there will be a point that my ego could be affected, and then I'll answer back in yes. Then there will be some sort of exchange of communication. Then that exchange of communication would always turn into negative. We quarrel. That's the result. Then at the end of the day, you apologize. So that's the thing. Anger is a necessary emotion that we have to experience. No. Now, expressing anger directly can be very, very uncomfortable. But the thing is, but it doesn't actually stop you by telling to your patient or somebody else that you are angry with them, especially with your children. No, you say, "Son, I'm angry already with you. You know the reason why I'm angry. You can actually tell. That will be necessary. That will be needed. No, you can always tell that to your patient if the patient actually trusts you. But if you have not gained the trust of your patient, there is no reason that you are going to say that you are angry with them. You can only say that, you can only speak to them about your anger if they have already trusted you. So like your husband, like your children, you could always say so, isn't it? So in that case, they will not be able to do what they are doing already. So they stop doing what irritated you so much. That's the thing. Human as we are. Yeah?
Yes,
So
okay.
do you follow?
Yes,
So,
we are.
sometimes when we are driving, this is the thing that you should not do. No, that's why other people are telling that you do not answer the phone call, any phone call when you are driving, because when you are driving and you are agitated because of that phone call, you could cause an accident, right?
Yes.
So that's the thing. So most of the time we have to regulate our anger. We have to regulate our reaction to to things, to events that happen around us. No. Now, in terms of etiology of anger, you see, since this is emotion, there is no single etiology that will actually tell what could be the cause, or else no human being can actually get angry already. No. That means to say all the anger that we have could be eliminated. But the thing is, even though how successful you are, even though you're a psychologist, at one point you feel so angry also. You get it? I'm a psychologist, but once in a while, I feel angry with some other people who are very important to me. You see, you human as well, yeah, because you see, as a human being, we are equipped with emotions, and emotions are encountered by us every single day. Now, let us try to look into some of the not theological factors that we know so far, but it will not justify under any circumstances that this is a specific reason of anger. It may, you see, like in the case of biological theories of anger. Now, in biological theories of anger, we are going to focus mainly on neurotransmitters. If you're going to look into your brain, there are neurotransmitters, no? These neurotransmitters are chemicals that are connecting neurons together. You know, our brain is made up of trillions of neurons. Sometimes they are physically connected by axon, but sometimes they are not. So in the brain, most of the time they are not. They're only interconnected by neurotransmitter. These are the chemicals like in the case of dopamine, norepinephrine, and serotonin. Most of the time, these are the things that are actually changed. Now, if there is increased dopamine, we tend to be very happy. But this happiness, if there will be an abnormal increase in dopamine, maybe we get high. You see? These are the things that are always, dopamine is the one that's very abused by drug addicts. They would like to elevate the number of dopamine. No? The norepinephrine and the serotonin. Serotonin is the one that is also causing our depression. That if there is increased serotonin level and decreased dopamine, then we will depress. We will be depressed. That's why there is what we call as serotonin reuptake inhibitors. You see? So we will know that when we will tackle psychiatric nursing already. We need to have all this balance within the brain. If there is abnormality, then there will be a problem. Yeah. So that's the thing. Now there are also psychological theories. Now in psychological theories, they're always speaking about experiences. Most of the psychological theories are talking about experiences, no? So if you're going to look at the various dynamics and learn responses that can cause anger, anger occurs as a result of frustration, build up of building up of frustration. Or according to Paquet in 1998, he points out that anger is caused by frustration and the feelings of powerlessness that precedes the expression of anger. You see, you're frustrated and you're very powerless. So what happens is that you tend to explode. Children of
Yes, it happened
today,
with me before.
it happens to you, right? Very
Yeah,
frustrated.
15 years I was يعني quiet with my husband because he was cheating on me, no?
Yeah,
After
okay.
15 years, I خلاص explode, I divorce.
You see, yeah, something like it's very difficult because in our culture, in your culture, isn't it? It's very difficult to quarrel with your husband, right? It's very difficult to shout. It's very difficult to confront, right? Because
Yeah.
by all means, in our culture, we are very patriarchal. No, we respect boys, male, right? Especially if they are our husbands or our parents, isn't it? Sometimes
Yes.
very, very powerless, no? We cannot confront. We see them already in our bare eyes that they are cheating, but we cannot do anything. That is the thing. We are very frustrated. And there are also, I know some people, including me also, something like, I know that my wife is very frustrated with me. Yeah? Simple things at home. Simple things at home. Like, for instance, the use of towel, right? My wife says, after you take a bath, you place your towel here, but I don't, right? When you are going, you say, will you please come and join us for dinner, but I don't, you see? So at one point, she would always express. Then she would explode. She would tell, yeah, yeah, and so on. Then quarrel comes. That's the thing. But of course, since I'm a psychologist, I know how to handle. No? But of course, handling the wife is very difficult. No? It's costly and it's expensive, right? You know the reason. You know what I mean. When you would like to handle your wife, sometimes you are going to bring peace. You're going to give them shopping money. Yeah, I'm just kidding you, of course. See, so this is the thing. An angry wife, there is no answer for an angry wife other than shopping money. Sometimes we do that just because of that, no? So frustration is actually happening. I am also frustrated, no? Sometimes with my students, with other people around me. Sometimes I really would like to shout inside my room to express my anger. I'm a psychologist, but I have to express my anger also. But of course, in acceptable way. I cannot shout in front of my students, but I would shout inside the toilet or in the shower room. Then after that, I feel better. That's the thing. No? Something like we learn how to cope once in a while because something, if we are very powerless, we tend to be very frustrated, then alas, we will be exploding. There will also be what we call as a positive reinforcement for this behavior that can cause inappropriate anger responses to continue into adulthood. Something like if this is being encouraged all the time, if we will not check this, then there will be a problem, especially among children. If the children will be unchecked, because you see the tantrum of our children, if the children are always unchecked, they can get what they want, then most of the time they will always have this when they grow old. That will be a problem that we have. There is also sociocultural factors that we know, the social groups, including families, that often display common patterns in degree of acceptance of expressed anger. There are groups that would always tolerate expression of anger. Yelling in the family sometimes would be acceptable. It depends on which family you belong to. But in my family, I don't. Normally, I say when my wife is already yelling, I move out. To diffuse the situation. When my son would actually notice that my voice is already a little bit increasing, they move out. No, that's the thing. Because for me, something like it depends on the culture where you belong to. If you accept yelling as a part of life, then it's okay. But most of the time, as a normal human being, becoming angry is okay. Becoming angry can be tolerated, but the way we express it, we have to check on that. That's the thing. No? All right, moving forward. Now, there are some conditions that we are going to look into. These are some of the clinical concerns that we actually consider we have, no? Medical conditions such as chronic illness or loss of body function may strain one's coping abilities, especially in the hospital. Imagine this. Imagine your patient to be separated from their family members. Or imagine the patient who could have lost a limb, maybe a foot or 2 feet, maybe a function of any part of their body is lost. So what could be the feeling of your patient? They could actually feel so angry, no? All right? The coping abilities may actually be impaired in any way. That will lead into what we call as uncharacteristic display of anger, especially when they're frustrated about the treatment regimen. For a few days already, they have been in the hospital, but nothing is happening. Normally, it's happening, no, in the hospital, especially if the doctors do not come on time. You see, the patient is already admitted, yet the doctors have not seen the patient yet for a number of hours. That's very difficult for the patient, no? Something like the doctors cannot actually feel this, cannot understand this. But if you are on the shoes of the patient, you'll see. They feel so frustrated because for a long hour they have been waiting, but nothing is actually happening. Adjust to the loss of body function, especially for those patients who are stroke. You notice that, especially if you're going to take care of the patients in the ward, in the geriatric ward, no? Something like the patient cannot do normally what they intend to do or what they are usually doing. They feel so frustrated, no? Or illness often means facing the feelings of powerlessness and frustration in meeting one's goal. If the patient is actually ill, they are very frustrated. They are very powerless. They cannot even give anything to their family members. Remember this, they are always family separated from their family. So they feel so angry because of that. No? Some conditions, including some brain tumors, definitely biological, no? And different forms of dementia may also directly contribute to inappropriate expressions of anger because of their influence on brain function. So normally, you see, usually even the family members would be surprised, no? If the patient is admitted, normally sometimes they do not actually feel so angry anytime soon, yet all of a sudden they exploded. So even the family members would be surprised. This could have been caused by some anatomical changes that could have happened in the brain. Now, remember this, Emerson Rose in 2005 found evidence that negative emotional states can contribute to cardiovascular diseases. This is the thing, that's why we are keeping on telling you, if you are going to feel angry all the time, then it could always lead you also to CBD, cardiovascular diseases. So if you really would like to have a very good heart, then you try to cope with your anger and your frustrations once in a while. Okay. Now, these are some of the lifespan issues that we are going to encounter among children. Children normally respond with anger when faced with frustration. Yeah? I believe, I know, you have encountered so many children like this, including me. I'm a victim of this. When you go to the mall, especially toy shop, no? When you have children and the child would like something and you said no. Have you encountered this with your children? When you say no, oh my goodness, they would actually express themselves loudly. They are not shy. They are not ashamed. Have you encountered this? So many times for me, you know. I feel like I feel so ashamed because people are looking at us, what's going on? But still the child would actually explode, you know, and so on. So out of frustration, the child will actually express because they are not rational yet. The thing that ruled them would be their emotions. They may not think about what people think. So what happens is that children would always do whatever they want, react whatever they do, right? Now, if they are raised in an environment where intense anger and violence are accepted, then they will be very violent also. If we are not going to check about this, you will see that children will also be violent, no? Something like they may also cause disrespect among elderlies also. That's the thing. They would answer back if they are not trained, no? If conversely, children who are taught about the nature of anger may think twice also before expressing what they have, and so on and so forth. No? So this is the thing. But often, always take note of this. Children, once in a while, or most of the time, are irrational. So we can always teach children on how to control anger. But if we are not going to control anger, we let children do as they wish, then there will be a very big problem, especially if they are always we tolerate that, then they think that it will be okay. They think that it's a reinforcement, it's okay, so that when they grow old, they can easily express themselves negatively by becoming angry with anyone. Sometimes this could also be deadly because no, they could kill anyone, because if you're going to be angry, very frustrated, if you cannot control your emotion, you could be homicidal or you could be suicidal. In psychiatry, we are always telling the patients about this. These are the first. This is the first thing that we are going to look into. No, the safety of the patient, especially on the feeling of homicidal and suicidal, the expression of anger at that. For adolescents, they know already somewhat what to do. They know they have already a sense of right and wrong. No? But in any way, anger is still there. In adolescence, this is often seen as a part of the developmental process, the process of separation from parents. This is the thing. Something like, especially the teenagers. Now, I do not know if you have children who are teenagers, but this is the usual process. They are very rebellious. They would like to live on their own. They would like to be independent. But the thing is, they are not independent. We have to recognize that. That's why when we check on them, they feel so angry already. They would shout on us. They would always get back on us. We feel as if they are disrespecting us already. But we should understand that this is a life process. So as the adolescents grow, then they will learn eventually that the attitude is not right. No? Hostility can also come from overstimulation from all they are dealing with, especially there are so many conflicts coming around, especially if you are going to look at the friends. So they are tense also. They are stressed also when they go home, they bring back all the things that they encounter among their friends. They may also have fears of being unable to control their impulses. During the time when they are actually becoming adolescent, they are very confused. They are trying to search for who they are. So they are very frustrated because at the end of the day, they cannot find themselves. They cannot even know what they want. Now remember this, if you ask them what they want right now, sometimes they cannot choose. See? This inability to concentrate, inability to choose what they want, inability to identify who they are may lead into frustration, may lead into anxiety, and eventually may lead into anger. That is the usual process that we are going to encounter among the adolescents. Adults, on the other hand, are a little bit rational in any way. Something like we know already how to, supposed to be, we know how to handle our anger already. Adults who must deal with difficult patients, adults who are actually dealing with difficult life experiences because we are solving our problems already. You see, there are so many problems that we have day to day in our lives. Raising a family is difficult, especially if you are alone. When you raise a family, often you are confronted with so many problems: rent, no, money, finances, among others, conflict with the wives, conflict with the husband. So many things that are actually happening. Some like these are too difficult to handle, so we give way. Okay, so that's one way. No, this anger can further complicate the disease by depleting our coping skills and interfering with the recommended medical treatment. That's why, as adults, we should have friends who can understand us. Now, who are the available friends that we have, of course, since if we are going to be married, our husband or our wives would be our best friend, but something like that. Sometimes our husbands or our wives would be a cause of trouble also. So we have a friends, our immediate circle, so that when we are angry, we go on someone's house and relax and let the time by. Nothing like that. It's a normal process. See? So that's how we handle situations. That's the thing. Yeah? So normally it happens. These are some of the conditions that we will actually look into. Older adults is actually more complex. Imagine for adults, we are raising family. We are raising children. We are sending them to school. We are trying to be stabilized with our job. We are trying to get money. We are trying to get what we want, what is needed in our life. Now, you go on the next stage when we are useless. We think that we are useless already. You know what I mean? Because we are retired. Our children are grown up already. We have no more job because we are retired. We are not earning any more money because we're retired. So you see, for elderly people, this may result of frustrations because we really would like to help, but we are frustrated. That could be caused by the following: number one, physical limitations. You see, because we cannot move anymore as agile as we could when we are younger. See, mental, something like, especially we have dementia already. Lifestyle changes. No? Remember when you are adult, you wake up every morning and prepare to go to the work, to go to your work. But when you are becoming an older adult, you do not know what time you're going to wake up because you have your time already, plenty of time already. But you have this plenty of time, but your purpose is also affected. This is the problem. Fear of dying, fear of losing loved ones, depressions, among others. So these are some of the things that we encounter. We are so vulnerable, particularly our elderly. So they feel so frustrated. That's why we have to understand them one way or another. Yeah. So it's already 3:30. I would like to continue this after our quiz next meeting. Is there any question that you would like to ask? Otherwise, I'll continue this next meeting. Sheikha, Wafa, Manira, is there any question? You know already the process of taking your IRAT or quiz, right? Online. So I hope that you will be ready by next week. No? We're going to take that during my time, before my time. That means, I think Tuesday, that will be Tuesday, right? We can actually take at 1:30 so that we can, no, no, no. So is it 1:30 our time next week? 2:30, right? We are going to have our quiz at 2:30, then after 2:30, that's 2:45, we're going to continue with our class. Okay? Don't be, you can always contact me anytime. You have my number?
Yes, doctor, we have.
Okay, it's always in the webs. It's in the PowerPoint that I actually give you. No, I don't think it's in PowerPoint. It's in the website. Nevertheless, I can give it to you so that you can always ask questions. Yeah, this is my number, so you can take that down also, just in case you would like to ask questions or anything. No, if I may be very helpful, then that will be okay. Yeah.
Thank you so much, doctor.
All right. So be ready. Read the first 10 pages, then have a good day. I really wish that you're going to make full mark during that time. Okay? Full mark. Yeah?
Inshallah.
Inshallah, doctor.
Yes. All right. Have a good day, everyone. Good luck.
Thank
See
you.
you next meeting. See you next week.
Inshallah.